RT is a 56-year-old American male who presents to Central Clinic today with symptoms of depression and COPD symptoms. His depression started 3 years ago after his MI, but over the past 6 months has been progressively worse. He has seen family medicine today, and they would like to evaluate his depression and have diagnosed him with MDD and also started citalopram and would like us to evaluate his inhalers for optimization. His past history includes STEMI, hyperlipidemia, COPD, and MDD. Socially, he is widowed, he is an IT specialist, and he drinks alcohol occasionally, which has been increasing lately, and he smokes 1 pack of cigarettes per day. His family history includes depression, and his father died of cardiovascular disease at the age of 62. His siblings report no significant disease. His medication list includes citalopram 20 milligrams daily for 1 week, increasing to 40 milligrams. Metoprolol succinate 50 milligrams daily, fluticasone 100 micrograms by inhalation twice daily, albuterol 2 puffs by inhalation every 4 hours as needed for shortness of breath, atorvastatin 80 milligrams daily, and aspirin 325 milligrams daily. His allergies and intolerances include adhesive and also citalopram, which he tried 3 years ago and reported erectile dysfunction and diarrhea, and stated that although he felt that the drug improved his symptoms, he did not like the side effects and stopped the drug. His prioritized problem list includes acute and chronic moderate MDD, high priority, COPD, high priority, post-STEMI, medium, hypertension, medium, prediabetes, medium, hyperlipidemia, low, and overweight, low. The assessment of his depression is acute and chronic uncontrolled moderate MDD based on the HAM score of 16, a HAM-D score of 16, and per the APA 2019 guidelines, he meets the DSM-5 criteria of depression. He has symptoms present that include depressed mood consistently for the past 6 months, no interest in hobbies or social interactions, constant feelings of guilt, fatigue, and worthlessness, and significant weight gain, as well as diminished concentration at work and that impacts his functioning at work. It's exacerbated by cold weather, holidays, and his recent birthday. He denies suicidal ideation or symptoms of bipolar or mania or anxiety. His contributing factors include modifiably alcohol use and tobacco use. His non-modifiable include family history, race, he's widowed in the past year, and his history of MI and his current COPD. His current therapy prescribed of citalopram is suboptimal and inappropriate because of his side effects that caused him to stop the drug in the past. While it is recommended per the APA 2019 guidelines, as second generations have less incidence of side effects than other medications in the class, it is not an appropriate choice for RT. The goal of therapy is early improvement as 20 to 30% reduction from baseline in depression rating scale in the HAM-D scales after 2 to 4 weeks. And that's correlated with a response and remission at 6 to 12 weeks per the CANMAT guidelines, and it is recommended to treat his depression for a minimum of 6 to 9 months. I would recommend discontinuing citalopram and starting bupropion 150 milligrams sustained release daily once in the morning, and may increase to twice daily after three days of tolerating. The combination of CBT therapy, which he's also been prescribed, with pharmacotherapy per the APA 2019 guidelines, is recommended with shared decision making to treat depression, especially in the setting of COPD, and it's also in the COPD guidelines is recommending bupropion. It's also FDA approved for smoking cessation at the same dosage, and it helps in weight loss, and it also does not affect erectile dysfunction, and it has less diarrhea than citalopram. Therapy should continue for at least 2 years since this is a relapse, and because of RT's risk factors. I'd also recommend that RT stop smoking, and I would initiate a nicotine patch at a dosage of 21 milligrams per day for 6 weeks, and then 14 milligrams daily for 2 weeks, and then 7 milligrams daily for 2 weeks. And along with this, I would recommend a nicotine inhaler to inhale 1 cartridge at least 6 times per day, up to 16 per day for up to 2 weeks. The rationale is that smoking worsens depression, COPD, and lung function as measured by FEV1, and stopping smoking may actually improve his lung function. I would also recommend healthy exercising and diet and also a weight loss program since RT is motivated. I would monitor for the safety for presence of suicidal thoughts and behaviors. I would monitor alcohol use since it may predispose RT to seizure risk, and also for common side effects such as anxiety and dry mouth and insomnia. I would also monitor for hypo or hypertension since RT's hypertension is currently beyond the goal of 138/86 with a pulse of 74. Bupropion does have an interaction with metoprolol, but this may actually assist in reducing blood pressure. I would recommend that RT keep a log of blood pressure and bring it in at his next appointment, and I would recommend to see him weekly for the first 4 weeks and then bi-weekly for the next 8 weeks to monitor for the efficacy of his depression medication. As far as the COPD, the assessment is chronic, uncontrolled, moderate, and symptoms since 2016 based on his persistent and progressive symptoms of mild shortness of breath with walking and limited exercise ability. There are no current signs of exacerbation, and he's not had any exacerbations in the past 3 years. His FEV to FVC ratio is 0.6. His CAT assessment score is 21, and this classifies him in the moderate GOLD 2 Group B COPD per the GOLD 2023 rating guideline. His eosinophil count is low at 50, and his AAT level is normal. His modifiable risk factors are smoking, prediabetes, and hypertension, as well as depression. His non-modifiable are age and cardiovascular disease. His current therapy per GOLD guidelines is ICS monotherapy, which is not optimal or appropriate since this is usually add-on for someone who has frequent and severe exacerbations or a high eosinophil count. What is recommended by the GOLD guidelines is a single inhaler LABA-LAMA combination early in therapy, and that has shown the best efficacy in improving lung function and shortness of breath over LABA or LAMA monotherapy alone. Since RT has exercise intolerance, the combination is highly recommended by a strong recommendation. I would initiate the LABA-LAMA single inhaler per insurance coverage, as there is no differences between the different brands as shown by studies. I would start an oro, 1 inhalation daily, as it's once daily dosing to increase compliance. Since his CAT score is 21, the combination inhaler would be more effective than either agent. Also, per the EMAX trial, to improve his baseline FEV1 symptoms and reduce his risk of exacerbation. I would stop his fluticasone inhaler and also continue his albuterol inhaler as needed for shortness of breath. I would also recommend that we maintain optimal blood pressure control and check for periodontitis, vitamin D deficiency, osteoporosis, and sleep apnea, as these factors affect prognosis. We could also consider annual low-dose CT scan to screen for lung cancer per CDC guidelines. Non-pharmacologic therapy would include pulmonary rehabilitation in a program. And per the GOLD guideline, this would improve quality of life and reduce exacerbations. I would monitor for safety such as cough, serum potassium, headache, tremor, tachycardia, insomnia, dry mouth, and bitter taste. I would follow up in 4 weeks for efficacy by reassessing the CAT and MMRC tool and his activities of daily living, occurrence of exacerbations, adherence, and inhaler technique. I would give him a written action plan and educate him on the side effects, also the benefits, and the benefits of healthy living, diet, and exercise management in pre-diabetes education and avoidance of metabolic syndrome, as this also may worsen COPD. And also I would assess his smoking cessation, inhaler technique, and his adherence. I would recommend yearly influenza vaccine as well as Tdap, zoster, and COVID-19 per CDC guidelines. Thank you.